Hello everyone, I'm Qiwen Yang from Peking Uni Medical College Hospital. My topic today is polymyxin antimicrobial susceptibility testing and ChiCAST breakpoints. My outline includes background, polymyxin AST method, polymyxin clinical breakpoint, and polymyxin AST report interpretation. Let's come to the background firstly. Polymyxin was first obtained in the secondary metabolism of Bacillus polymyxa in 1947, and it is a polypeptide with antimicrobial activity. The drug was used in the clinical treatment of gram-negative bacillar infection in 1959. In recent years, due to the increase and prevalence of MDR gram-negative bacillar, especially carbapenem-resistant organisms, clinical optimal drugs are very limited, and polymyxin has returned to the clinical use as an important choice. Several guidelines recommend polymyxins as an important treatment drug for CRO infections. In 2020, CISI changed the polymyxin clinical breakpoints to eliminate the polymyxin susceptibility breakpoints and reported only intermediate and resistance. ChiCAST recommended susceptible as less than or equal to 2 microgram per liter and resistance greater than 2 micrograms per liter. Clinical breakpoints. US CAST use S less than 2 and R greater or equal to 4 as clinical breakpoint. So, how to accurately carry out the susceptibility testing of polymyxins and standardize the interpretation of the report is an urgent problem. Polymyxin is a group of polypeptide antibiotics, which have 5 main components: polymyxin A, B, C, D, and E, among which A, C, and D were not developed due to toxicity. Polymyxin B is active in vitro, and polymyxin E, polymyxin sulfate, is active in vitro, and the cell size is specified for AST testing. The second part is polymyxin AST method. Firstly, the E-test methods, we have come to its characteristic of this method. VME against Enterobacterialis was 9.4% to 26%, and VME for E. coli reached 40%. For Enterobacter cloacia was 25%, and for Acinetobacter baumannii was 38%. The disk diffusion method. Overall, the VME data for the home Enterobacterialis, Acinetobacter baumannii were insufficient by disk diffusion, so it is not a suitable method for collecting ST method. The Phoenix method. The VME of Phoenix was 24.5% for all Enterobacterialis and 87.5% for Enterobacter cloacia. The VME of Phoenix was 41.4% for Acinetobacter baumannii and insufficient data for Pseudomonas aeruginosa. Microscan method. The VME was 0 to 4% for Enterobacterialis, 0.8% for gram-negative bacteria, and 5.3% for non-fermentative bacteria. Vitac2 method. The VME of Vitac2 method was 3.7% to 36% for all Enterobacterialis, 60% for E. coli, 81% for Enterobacter cloacia, and 37% for Acinetobacter baumannii. The data of Vatican II method was insufficient for Pseudomonas aeruginosa. The agar dilution method, the VME of Acinetobacter baumannii detected by egg dilution method was 3.4%. And in the year of 2020, CISI recommended colistin egg test for the colistin resistant detection. The VME of colistin egg test was 0.5% for Enterobacterialis, 0 for Pseudomonas aeruginosa, and 14% for Acinetobacter baumannii. And in the same year, CLSI also recommended colistin burst disk elution. The abbreviation is CBDE for colistin resistant detection. The VME of CBDE was 2.5% for Enterobacterialis, 0 for Pseudomonas aeruginosa, and 5.6% for Acinetobacter baumannii. So let's come to the principle of polymyxin susceptibility testing. The standard Ross microdilation method recommended CSI and ChiCAST was preferred for polymyxin B and colistin. Colistin burst disk elution test and colistin egg test recommended by CSI can also be used. The commercial burst microdilation methods, which have been verified and proved to be reliable in clinical laboratory, was secondarily recommended. Drug gradient diffusion methods, such as disk diffusion and e-test methods, are not recommended for clinical laboratories. Automatic instruments methods are not routinely recommended unless they are explicitly permitted by the manufacturer of the instrument board and their performance has been verified by clinical laboratories to meet the needs of clinical testing and reporting. And the possible risk of automatic instrument methods should be informed to the clinic when used under certain limited circumstances. The quality control strain for polymyxin susceptibility testing should include a sensitive strain such as ATCC 25922 and a resistant strain such as MCR1 producing E. coli NCTC 13846. The susceptibility testing results of polymyxin B and colistin can be inferred from each other. The third part of my talk is polymyxin clinical breakpoint. There are several international breakpoints in today. Firstly, the CSI breakpoints only have intermediate and resistant breakpoints, and ChiCAST breakpoints has susceptible breakpoints and resistant breakpoints. We also have US CAST breakpoints and FDA breakpoints for our use in clinical. If we want to set a rational clinical breakpoints, we must just come to see the ECOF. Firstly, ChiCAST has published the ECOF values of polymyxin against various strains based on multi-region and multi-tissue monitoring data. CSI can refer to the ECOF values of polymyxin against the corresponding species. It is not recommended to directly use ECOF value to determine the susceptibility and the resistance of clinical strains with undetermined breakpoints in clinical practice, but ECOF value can be used to determine whether the strain are polymyxin wild type or acquired resistant strains, which plays an important role in formulating clinical breakpoints. So the colistin ECOFs published by ChiCAST is 2 for most of the Enterobacterialis and 4 for Pseudomonas aeruginosa. We have also come to the PKPD index of polymyxins. From the mouse sign infection model, we can see that polymyxins show rapid concentration dependence on Pseudomonas aeruginosa, Acinetobacter baumannii, and Klebsiella pneumonia. So the PK/PD index of polymyxin is free AUC and MIC. PK/PD target values of polymyxins. In the mouse sign infection model, colistin treatment reduced Pseudomonas aeruginosa and Acinetobacter baumannii colonies by 2 log 10, and Klebsiella pneumonia colonies by 1 log 10, and the PK/PD target values for colistin and polymyxin B were both less than 20. In the mouse sign Klebsiella pneumonia infection model, polymyxin B did not reduce the number of colonies of this strain by 2 log 10. And the PK/PD target values of Pseudomonas aeruginosa and Acinetobacter baumannii of colistin in the mouse pneumonia model were significantly higher than those in the sign infection model. Based on the above PK/PD target values of colistin and polymyxin B, the 2019 Polymyxin International Consensus Guidelines recommended the steady state AUC SSAVG of colistin reached 50, which was equivalent to the steady state average blood concentration reached 2 milligram per liter. The steady state AUC SSAVG of polymyxin B should be 50 to 100, which is equivalent to the steady state average blood concentration, which is 2 to 4 milligram per liter. For the optimization of the treatment of regimen of polymyxin drugs, it is recommended to monitor the therapeutic drug, obtain the PK of the drug in the patient body, and formulate the treatment plan based on the MIC of the isolated pathogens. So we can see from this slide that PTA and CFR of CMS dose for different renal function conditions. And we also have the clinical application and efficacy of polymyxin in different types of infections. The clinical efficacy of polymyxin combination combined with other antimicrobial drugs in the treatment of a CRO infection is related to the site of infection and pathogenic bacteria. Polymyxin combined with one or more antibiotic is recommended. Intravenous antibiotics combined with aerosol polymyxin inhalation are recommended for the treatment of pulmonary infections caused by MDR gram-negative bacteria. Intraventricular or intrathecal injection of polymyxin is recommended for the treatment of ventriculitis or meningitis caused by CRO. CMS is recommended for the treatment of urinary tract infections caused by XDR gram-negative bacilli, and for CRO infection, early, full dose, combined and full course of treatment of polymyxin is recommended, and polymyxin combined with other nephrotoxic drugs may increase the risk of AKI. So from the large amount of the clinical evidence, we can also see polymyxin combination therapy can improve the survival rate of BSI patients caused by KPC producing Klebsiella pneumonia isolates. And we can see from this paper published in CID that the mortality rate was 54% in the monotherapy group and 34% in the combination group. And polymyxin-based combination therapy improved the survival of XDR Acinetobacter baumannii causing bloodstream infections. We can also see that polymyxin IV combined with aerosol inhalation can significantly improve the clinical efficacy of VAP infections caused by MDR gram-negative bacilli. And we also found combined intravenous and intrathecal and intraventricular and administration of polymyxin B significantly reduced the mortality of central nervous system infections caused by MDR and XDR Acinetobacter baumannii. So the final part of my talk is the polymyxin SD report interpretation. Firstly, we can have to find the clinical breakpoint of polymyxin, which were published by ChiCAST. Based on the ECOF and PK/PD breakpoints of polymyxin, this consensus recommends that the breakpoint, which is susceptible, is less than or equal to 2 mg per liter, and the resistance is greater than or equal to 4 mg per liter, be used as the clinical breakpoints for susceptibility report of Enterobacterialis, Pseudomonas aeruginosa, and Acinetobacter baumannii. And in the comments, we also annotated that polymyxin susceptibility results must be annotated. And we must also find the Morganacea, including Proteus, Morganella, and Providenella, and Serratia macensis are naturally resistant to colistin, so it is not necessary to test the susceptibility of colistin. The drug susceptibility testing results of colistin and polymyxin B are equivalent and can be substituted for each other. And MICs of polymyxin must be tested using reliable methods. And in the report, SD report, we must obey the principles and key points in the SD report annotation. Firstly, to reduce the irrational use of polymyxin, we must say polymyxin is mainly used for the treatment of MDR and XDR, Enterobacterialis, Acinetobacter baumannii, and Pseudomonas aeruginosa infections. The drug has a certain degree of nephrotoxicity and should be used with caution. During the treatment, the renal function should be dynamically monitored, and the combination with nephrotoxicity drugs should be avoided. And next, to improve the clinical efficacy of polymyxin, it is recommended to use a maximum loading dose of polymyxin in combination with 1 to 2 other in vitro active antibiotics. And it is also suggested that the average steady-state plasma concentration of polymyxin B should be maintained at 2 to 4 mg per liter and colistin at 2 mg per liter. Finally, the treatment recommendation for specific size infections include additional raised note for VAP and HAP, and in addition to intravenous polymyxin administrations, intraventricular or intrathecal injection of 5 mg polymyxin B or 10 mg CMS per day is recommended for CRO infections. Comment on lower urinary tract infections is polymyxin B is not recommended for the UTI treatment. So this is a report of my topic. Thank you very much.